My father will be mortified. My mother will rejoice. We are going to drink a lot of wine and keep talking about menopause. Welcome to Wednesday Wine with Ana Belaval, live from Chicago. Listen to me. You had so many questions about what to do with the hot flashes. They're driving you crazy, and you're trying all sorts of strange things that work for you. No big deal, but maybe are not sustainable. So today we're going to bring Chicago's menopause guru, the goddess of the life change. Dr. Lauren Streicher not only left her practice to focus on older women and their sex lives and their issues, but is writing 10 books about menopause. She's the doctor that the last time we mentioned over and over again when we spoke to our bloggers, Denise and Celeste, because not only does she commit to older women, but she also created a center at Northwestern Medical here in Chicago for menopause, which is unheard of in a lot of part of the country. So wherever you're joining me today from, hi Jeannie, hi Ivy, hi Maria, wherever you're joining me, please feel free to ask her any questions. Obviously, you're not her patient, so she's not going to tell you this is what you have to do. She's going to tell you what she usually recommends for that situation. But it is imperative that you always talk to your doctor and find that specialist that can help you out with this, because it's a reality for us midlifers. And it can start as early as 39 and 40. We saw it last time. I am so happy. All right, Patty, I'm going to say happy de Cinco de Mayo once, and then I'm going to move on, because I worked at Univision for many years, and my Mexican friends would take my Latino card away if I celebrate Cinco de Mayo. You go ahead and drink all your margaritas. I'm going to have my wine. Oh my God, Pierce is like, I've been waiting for this all day. So without further to-do, like my father would say, let me bring in Dr. Lauren Streicher. Hi, Dr. Streicher.
I am so happy to be here with my wine.
Good.
Thank
so
you.
I don't have to quit my wine when menopause hits?
Are you kidding? It is mandatory. Although I will say, for some people, red wine can cause a flash, so you might have to switch to white until we get that under control. But no, wine is one of the best ways to get through this time of life.
To get through this time of life. You probably don't remember me because you've had so many patients throughout your career. But when I was 33 years old, I was pregnant with my daughter. I was your patient. And you said, I use my married last name. And I was pregnant, and you took us through the whole thing. And I remember vividly because you said, all right, you're going to go get this genetic test, and I won't be able to deliver you. Very matter of fact, you said, because I am not going to deliver any more babies. I'm going to go focus on older women and their sex life.
And then here we are. Now you're no longer 30, right?
I'm 46 and I need you badly again.
Exactly. See how these things come full circle? It's perfect.
So why did you want to do this? Why focus on menopause?
You know, one of the things I decided is that I love delivering babies. I mean, who wouldn't? It's fun to be part of someone's life and to do that. But what I realized is that if I wasn't delivering babies, there were plenty of other good obstetricians in Chicago who would deliver those babies just fine. And what I wanted to do was to reach out for an unmet need, because I was realizing with my patients that there were so many women that were approaching perimenopause, menopause, and that these problems took time. And you know, when you go to see your doctor, your OBGYN, quite frankly, they usually have about 15 minutes to spend with you. Yeah. And I thought, this is not going to work for me. I want to really do the deep dive. I want to know this stuff. I want to be an expert in this area. Let someone else deliver the babies. So I went to Northwestern and I said, I want to start a sexual medicine clinic and a menopause clinic. And they kind of laughed. No, they laughed a lot, actually. And it was 4 years in development. And they finally said, okay, let's do it. And much to their surprise, but not mine and not yours, we have been so successful. I mean, the doors are practically breaking down from women. And just today I got all the comments, because we, you know, when you go to the doctor, they ask you sometimes to fill out a comment sheet afterwards. And the comments are, Thank you. You're my fifth opinion. No one else has been able to help you. And there's so much satisfaction in the fact that we are able to give information and solutions. I am completely solution driven. It doesn't do you any good for someone to say, yeah, women have hot flashes and dry vaginas and they, recurrent urinary tract infections and can't sleep when they go through menopause. That doesn't help you. We need to say to someone, this is why it's happening. These are your options, and we're going to help you feel better. So it's been very satisfying work.
Oh my goodness. Why in medical school, when you guys are doing your specialty in OBGYN, why don't they offer future doctors that specialty?
Well, first of all, it's not an official specialty. There are certain official specialties like fertility and oncology and all this. So this is an area of interest as opposed to a specialty. But the real question is why aren't they learning about it? And the truth of the matter is they don't have time. When they do a 4-year residency in OBGYN and they have to spend so many hours in labor and delivery and so many hours doing gynecologic oncology and gynecologist and all of this. And we've had this center in Northwestern for 4 years and the residents don't rotate through. And quite frankly, it's not because they don't want to, they would like to. They'd like to know more about this. They know how important it is, but there's just no time. I didn't learn about this stuff when I was a resident. This is something that I had to take on and learn much later. And quite frankly, it happened because I was writing books. And my editor said to me, love to have you write a book about sexual medicine and menopause. So I started to do the deep dive and I thought, this is not only really interesting, but there's a lot here that we can do to help women. So this is not something I learned as part of my medical education. I'd like to change that, but realistically,
Right. Okay. So my first question is, I didn't know there was a difference between perimenopause and menopause.
Yeah. So basically the way that I describe it is menopause is when your estrogen is empty. Your ovaries are no longer producing estrogen and they're never gonna. Sometimes it's surgical or as a result of chemotherapy and they're just, gone. But sometimes it's just they are out of business. But leading up to that is perimenopause. And perimenopause, I always say the only thing that's predictable about perimenopause is that it's completely unpredictable because 1 week your ovaries are pumping out estrogen, the next week they're not. You're getting hot flashes, they're coming, they're going, your periods, you're wearing white, you have no tampons. That's when you're going to get your period for sure because you're not expecting it. And the problem is
I was in high school again, Dr. Streicher. I'm in high school.
We're going to get to that because I actually get crazy when people talk about this as a second puberty, and I tell you why. But I'm just going to circle back to that in a second. But the thing about perimenopause that really blindsides women is how early it starts. I think when we think about menopause and menopause, you're thinking of grandma. You're not thinking of I'm 41 years old and I'm hot and I'm sexy and I'm at the prime of my career. And then what the hell is this when suddenly I'm up with hot flashes and my periods? And most people think that there's got to be something else terrible wrong with them, which is made even worse when they go to their doctor and their doctor says, you're fine. They get a hormone level and their hormone level's normal. Well, of course it's normal because your hormones are on a roller coaster. Right. So maybe on Tuesday at 2:00 when you had your hormones checked, they were normal. And then they take the dive 3 or 4 days later. So perimenopause can be a very confusing time. And quite frankly, it's not always easy to diagnose because where a hormone level might be helpful, it might also just be confusing. So perimenopause is one of those things that, quite frankly, you need to be a little bit expert. But I'm going to circle back to what you just said because I want to address that. The New York Times just did an article and they talked about how menopause is like a second puberty. And I wrote a letter to the editor, which didn't get published, oh well. But the point is no. And the difference is puberty lasts 2 or 3 years. You get acne, you're miserable, your periods all over the place, and then it goes away. But you don't get heart disease, you don't get bone deterioration, you don't lose sleep at night. It's completely different. You spring back. It's a short period of time. It's a defined period of time. And it's miserable, but it's miserable for different reasons. When women go through perimenopause and menopause, this is not a 2-year thing where you get a little acne and your periods get irregular. I always say you don't go through menopause, you enter menopause. Because once you are in menopause, you do not exit. Your ovaries do not start making estrogen. So just like people think, okay, I'm done with menopause. If you're dead, you're done with menopause. Otherwise, you're never done with menopause because just because the hot flashes go away doesn't mean that you're still not in menopause. You still have to think about your bones, about your vagina, about your heart. All of those things continue on. And that's why this is so important, because women go through menopause, 52 is the average age, as early as 40, 45. Our life expectancy, we're well into the 80s and 90s. So for some people,
Yes.
they are living literally half their life in menopause. So we need to say, okay, let's get this right.
So when Pierce D says the last 5 years have been hell, they're probably perimenopause. And when she enters menopause, that's when the period stops and you continue.
Well, when she says the last 5 years have been hell, and we need to ask Pierce exactly why, because hell has a lot of different parts to it. But for some people it's hot flash hell. And that's my second book. The first book that was just released today, Slip Sliding Away, Turning Back the Clock on Your Vagina. And of course, this is about vaginal dryness and urinary tract infections and all of that. But hot flash hell, when we talk about how long hot flashes last, one of the big misconceptions is that, it's going to be a year, 2 years, I'm going to tough it out and it's going to go away. No, we know from very good studies that have been done over a 20-year period of time that the average amount of time that a woman experiences hot flashes is 7 to 10 years. And it happens to have a lot to do with genetics. So as an example, Caucasian women, on average, 7 years. Black women, 10 to 12 years. Asian women, 4 to 5 years. And if this isn't about diet, it doesn't matter whether you eat, cheeseburgers or eat, rice and fish. This is genetic. So the point is that when I hear from someone 5 years, it's like, oh yeah, and you might have another 5. And quite frankly, I'm sure we have people out there that it is forever. So no, you don't dress in layers and get a fan. We fix it. We make it go away.
How do you fix it?
That? How you fix it? I wish I could just say, here, easy fix. But so my second book about hot flash hell really goes through all the fixes, because no one should have to put up with this. No one. And there are a lot of hormonal and non-hormonal things, and we can take a little time and go through all of that. But the point that's so important is hot flashes are about more than just being miserable. I mean, that would be enough, that you can't sleep and you're sweating and you're taking, sweating through your clothes. But what we now know about hot flashes is that hot flashes actually impact on your heart. We know that women get increased risk of heart disease after menopause. And quite frankly, it's the flashers. It's the flashers that have more heart disease, because it actually causes changes in your blood vessels. When we look at cognitive function, we can talk about that. You can't remember why you walked in the room, And a lot of this is because of the hot flashes and the changes it causes in the brain. Bone health. We know that bone health, women lose bone after menopause, but it's the flashers that lose it even at a greater acceleration. So my big mantra out there is flashes are not something that you just say, I'll tough it out and I'm going to get a fan. It's, no, we got to make these flashes go away, because they are actually harming you. I have an article on my website called, Think Your Hot Flashes Can't Kill You, Think Again, which is a little dramatic. But the point is that hot flashes have an impact on your heart, on your bones, on your brain. So we got to fix them.
How do we fix them?
Okay, well, the short answer to that is that the best way to make hot flashes go away is with hormone therapy. And hormone therapy, for the overwhelming majority, it is effective, and women do great with it, but it has to be given properly. It has to be properly monitored. It has to be in the right doses. Now, having said that, even though for most women hormone therapy is safe and is appropriate, there are some women who either have a medical reason that they can't take hormone therapy, or that's just their personal preference. And fortunately, we have a lot of non-hormonal fixes for hot flashes as well. We have some that are medications that are actually FDA approved for that purpose. And then we have some that are not FDA approved for that purpose, but we know that they work. One of the questions that always comes up is, well, what about the over-the-counter stuff? Hey, I'm going over to, Whole Foods, and I'm going here and there, and I'm going to buy all these botanicals, and it's safe, and that's what I want, black cohosh and all of that. And unfortunately, most of these have been scientifically shown to not work beyond the placebo effect, meaning placebo effect is real, but it just doesn't last. So if I tell you that green M&Ms are going to make your hot flashes go away, and if you believe it, it will make your hot flashes go away for a while. but then 8 to 12 weeks later, they might come back. So the exceptions to that. So what botanicals can you actually take that have been scientifically shown to work beyond the placebo effect? Gosh, in some women, absolutely. Also, there's something called, and I don't work for any of these companies. I always give this disclosure. I work for nobody. In my books, I talk about a lot of products. I give a lot of suggestions. No one paid to be in my book. I just give you the facts. I just give you the real information. There is a botanical called Relazin. These are all over the counter. There's one called S-Equal. Those are the ones that really seem to help, with the caveat that there's a big difference between the woman who says, oh, I'm a little hot, and the woman who is like stripping naked and sweat is pouring down her. You know, if someone has those severe hot flashes, we just have to get the big guns out and do something prescription, either hormonal or non-hormonal. But for a woman who's, you know, saying, okay, I don't really want to try something prescription, I want to go another direction, start with that. We also know mindfulness, cognitive behavioral therapy have been shown in very good studies to help. Yoga, I love yoga. Yoga's good for you. It does all kinds of good things. It doesn't help your hot flashes. So, but these things have all been studied. You know, it's wishful thinking and hocus pocus. We have actually, people always think no one's studying this stuff. No, we're studying this stuff. There's a lot of really good information out there. It's just, where do you get this information? Who knows this information?
Dr. Streicher, what about marijuana? Deborah wants to know if it helps.
Deborah, you are not the only one. So cannabinoids are really interesting because, of course, we know that women are using cannabinoids. The numbers are going up and up. And here's the issue, is that it has not been studied. When I talk about stuff has been studied, cannabinoids has not been studied in menopause. We are starting to get some information. So a couple of things you need to know. One, there's cannabinoids come in a lot of different forms, right? So we know that edibles, you have to be particularly careful because women in menopause metabolize edibles different than other people, and it's actually more slowly. So this is an issue because a woman will have, like, you know, a piece of the brownie, and 30 minutes later, she's like, oh, it's not working. And then she'll have another piece of the brownie. And then by the time she's had the whole brownie, 3 hours later, she is like in a coma, you know? So if you choose to use an edible to help with hot flashes and sleep and all of that, the rule is go low, start slow. You have to be really careful. I'm not going to tell you don't do it. I'm just going to say be careful with the edibles. As far as other forms of cannabinoids, and I'm talking specifically hot flashes now, has not been studied. I wish there were more studies on it, but we do know that postmenopause women do metabolize cannabinoids differently than premenopause women. We can talk, if we get into in my book, Slip Sliding Away, I do talk about CBD oil and lubes and all of that in terms of what that does for the vagina. In book, I think it's book 5 or 6, when I talk about orgasm. You know, everyone should come and learn about orgasm. You know, we talk about the role of cannabinoids on the clitoris. So we're looking at it. We just don't have good studies.
Got it. Okay. I remember when my mom went through menopause and they suggested hormone replacement therapy. My mom was in her 50s. Mom's now 82.
Yeah.
She was like, I will never take that because it's going to give me cancer.
Right. One of the biggest myths out there, and it is a myth. So this is what we know, and it's a long answer, and I'm going to go through it in great detail in my book, but I'm going to give you the short answer. The short answer is, in that big study that scared the bejesus out of everyone, that was released almost 20 years ago, the Women's Health Initiative study, that they said that there was an increase in breast cancer, so everyone stopped taking it. And there were so many issues with that study. Number one being that the average age of the woman in that study was 65, as opposed to when women actually go through menopause. And they were looking at women who weren't flashers because they didn't want the flashers, because they didn't want them to know if they were getting the real stuff or the placebo. But this is the big take home. This is the big take home. There were 3 groups of people: placebo, estrogen alone, estrogen and progesterone. The estrogen alone group, which was released later, had 0 increase in breast cancer, and in fact had a 30% decrease in breast cancer and a 30% decrease in all-cause mortality. That never made it to the news because it was the estrogen and the progesterone group. People take progesterone to protect the uterus along with the estrogen. It was the estrogen and progesterone group that showed a slight increase in breast cancer, which was now felt to be from the form of progesterone that women were using, which I no longer prescribe. So what we now know is that hormone therapy does not increase the risk of cancer. And we're very careful about how we give it. And we have all kinds of alternatives. And certainly my approach to someone who is at very high risk might be a little different, but it's so different. I mean, it's so different. This is not your mother's hormone therapy. You know, we give it through the skin. We give it transdermally. We use bioidentical plant derived. We give different progesterones. So, you know, it's about getting the right information. But the problem is that so many women, they go to their doctor, as you said, and their doctor isn't able to give them the right information, even if they have a really, really, really good doctor, because they may not be an expert in this. So what I tell women, I never say go to your doctor. I always say go to a menopause expert, and your doctor might be a menopause expert, and you could certainly give them the benefit of the doubt. But if they look at you like, you know, no, hormone therapy is dangerous, or I don't have a solution for you, just because you're told that there's no solution doesn't mean there's no solution. You need to see someone else. And in Chicago, of course, I want everyone to come to the Northwestern Menopause Center for Sexual Medicine and Menopause. People who are watching this outside of Chicago who can't get down there, there's a wonderful website people need to know about, the North American Menopause Society, which I think you mentioned last week, and that's menopause.org. And you go in there and you go to the tab, find a practitioner, you put in your zip code, and you find a certified menopause practitioner who can help you. There is someone out there who can help you.
I love this. All right. I want to ask this question because it seems kind of relevant when you were talking about it. Mary says, I had breast cancer and was put on letrozole, but then they realized or thought I should be on tamoxifen. I'm perimenopausal. This stopped my period, but cannot getting your period cause uterine cancer.
Mary, that is such a good question. And let me give you the very specific answer to that. What we know is that what increases the risk of uterine cancer, which is the most common gynecologic cancer, by the way, highly curable, but still we don't want to get it. The number one thing that increases the risk is if you have an abnormal buildup in the lining of the uterus. And there's a number of things that can cause that. One is if a young woman or someone is perimenopausal and they're making estrogen, but they're not making progesterone so that they don't shed the lining, and they can get a very thick lining, which doesn't always cause cancer, of course, but increases the risk. One of the things with tamoxifen is a specific kind of drug, which is called the selective estrogen receptor modulator. And basically in English, what that means is that it suppresses estrogen receptors on the breast, which we like. That's a good thing. That's why you were given tamoxifen. But it can also activate estrogen receptors in the uterine lining. So we're always very careful when we give women tamoxifen that if you have any abnormal bleeding, that we check it out and we make sure that you're not getting a buildup. But because we know so much about it now and we monitor women on tamoxifen so carefully, and women who aren't getting their period, who are still making estrogen so carefully, the rates of uterine cancer are so low. And so the take home here is, if you're worried about it, certainly that you should talk to your doctor. And absolutely, if you're getting heavy bleeding, spotting, irregular period bleeding, most times it does not mean there's a problem. Most times it is not serious, but you should never ignore it. That's book 6. Don't go with that flow, which is abnormal bleeding and when you should worry and when you shouldn't. We're going to cover it all. But you are honestly. But this is why I decided not to write one book, because it would be like 2,000 pages. And people just want to go and figure out what their issue is. And there's some menopause books out there that are, they're not bad, that are pretty good. But what I found is that women don't want to wade through all that. If they've got dry gynae, they want to download Slip Sliding Away. If hot flashes are your big issue, that's the one you're going to download. And you might end up, I hope getting more than one. But the point is I am all about, let's solve these problems and get right to what's important to you.
All right, let's get to some questions. Where the heck did my energy go? I want it back along with my ability to sleep. Help.
I can tell you where your energy went. It went where your sleep went. The reason you're exhausted all the time is because you're not sleeping. And that is one of the number one issues that someone comes to the clinic and they're like, I'm just so exhausted. Oh, and I don't want to have sex. I see that pillow and all I want to do is sleep. Well, of course, because we know that if you're getting less than 7 hours of decent sleep a night, not only are you going to be exhausted, you're going to be, your cognitive function is going to be completely off. You're not going to want to exercise. You're going to gain because your leptins and ghrelins and all your hunger hormones that are controlled by sleep. So if you were to ask me, what is the number one thing to fix to make so many menopause symptoms go away? It's sleep. it's sleep. You gotta sleep. And what we know about sleep is, of course, hot flashes wake you up, but there have been some very good studies done, actually right here in Chicago, at the University of Illinois. There's this amazing, amazing professor, Dr. Mackey, who is doing all these studies on sleep and cognitive function. And she actually wires people up when they sleep and measures their temperature. And so we know that you're not even aware of most of the hot flashes you're having. You know, the bad ones might wake you up, but throughout the night, you're having not as bad hot flashes that are enough to disrupt your sleep so that you don't get a good night's sleep. And then the next day you get up and say, I'm exhausted and it's 8 o'clock in the morning. You know, what the hell? How am I going to get through the day? So sleep is critical, and then you will get your energy back. I promise you. I promise you.
How do I get my sleep back though? Because I've been hitting the melatonin. I've been lavendering my whole body.
Yeah, you got to get rid of the hot flashes. I mean, there's no question. And sleep, look, I don't want to say, I'm going to oversimplify. There's many other reasons why people can't sleep. Let's talk about, you know, the COVID pandemic, just for starters. I mean, we all have stressful lives and all this stuff going on. And, you know, it's always interesting that right when the women go through menopause is also when their kid comes home with a, you know, pierced tongue and a tattoo, and their husband's like having an affair and they're losing. I mean, you know, it all happens at this time. And so then you can't sleep because you have your hot flashes and you're stressed and you're anxious. And some people have things like restless leg syndrome and sleep apnea. So when we dress sleep, I don't mean to oversimplify and say, oh, it's just hot flashes. There are many things that can cause sleep disruption, but that's the problem, is that this is very often multifactorial. It's not like there's one thing that someone comes in and says, I can't sleep, fix it. It's like, oh, here, do this. You know, we can talk about sleep hygiene until the cows come home, and that is important, you know, to turn off the devices and to, you know, all of that. But then for someone that it's just not working, sometimes we do a sleep study. We have sleep specialists at Northwestern that they actually have you go and stay overnight and wire you up and see what's going on. Do you have restless legs? Do you have sleep apnea? Are you having flashes you're not aware of? So we have the tools to help, but it's sometimes not the first thing we try.
It's not an easy answer. Okay. All right. This one's half and half Spanish, half English. Si me sacaron la matriz, will I have
the
menopause
second half.
early?
Will I have menopause earlier?
All right. So this means if she had a hysterectomy.
Yeah. Okay.
Will she have menopause early?
Okay. I'm so glad that this came up, because so many women think that a hysterectomy puts you into menopause. And the answer is no. A hysterectomy is removal of the uterus. Your uterus does not produce hormones. So if you have a hysterectomy, but your ovaries were not removed, the hysterectomy will not put you into menopause. We talked about when do you know you're in menopause and perimenopause and all of that. Well, it gets a little confusing if you had a hysterectomy, because you can't go by your periods, or a woman who's had a uterine ablation or an IUD, or, you know, all of that. So, but the question is will she go through menopause earlier? And the answer is maybe. Science has shown that women who have a hysterectomy are not going to go into menopause as a result of the hysterectomy, but statistically may go through menopause a little bit earlier than they were genetically programmed to do so. And we think that that has something to do with the blood supply to the uterus. Now, a lot of times it so happens, my first book is about hysterectomy, actually. It still actually sells really well. And the most common time for women to have removal of their uterus, to have a hysterectomy, is between ages 40 and 45. Guess what else is happening around that time? Perimenopause. So a lot of times a woman will have a hysterectomy at 44 or 45, and then she will go into perimenopause or menopause and say, hysterectomy. And the reality is it may have just been a coincidence because of the timing. So just to be clear, hysterectomy, removal of the uterus, does not put you into menopause, only if your ovaries are removed.
Got it. What is the youngest age you can start premenopause?
So we have very specific definitions. Menopause is defined as your ovaries winding down after the age of 40. If someone goes through menopause before the age of 40, that is either defined as premature menopause if their ovaries are removed, because then they're done, or a phrase that a lot of women are not familiar with called premature ovarian insufficiency, POI. This affects 1% of women who very often will go through menopause or seeming to go through menopause before the age of 40. And the reason we call it insufficient because sometimes it'll kick back in. It depends on why this has happened. There are a number of reasons why it might happen. Sometimes it's genetic. Sometimes someone might have an autoimmune disease. Sometimes it's a result of chemotherapy, radiation, cancer treatments. Yes, sometimes it's just unexplained. We don't know why. Sometimes it's a chromosomal issue. So if someone does experience this before the age of 40, we do a very extensive evaluation to see why that has happened. And then, of course, address the fact that, okay, hey, you're 38 years old. We got to make sure that your bones are okay. Your sex life is okay. Get rid of these hot flashes, your brain, your bladder, all that stuff. So, but the youngest for what we consider to be a normal time to go through menopause is anytime after 40.
Got it. All right. Are there bad side effects of using HRT?
So, Anita, again, one of these myths out there, when we talk about hormone therapy, for the most part, when it's given correctly, given carefully and monitored, no, most people do great. But like anything, it might not be that the first thing I try might not be the best thing for you. Sometimes I might put someone on hormone therapy and they might experience, a little bloating or maybe a little bit of bleeding. But when you talk about side effects, there's really two categories of side effects as far as I'm concerned. One is the ones that are just, okay, we got to tweak this. This isn't what you're looking for. It's kind of unpleasant. And then there are the serious side effects. The number one serious side effect, we talked about the fact that it does not increase the risk of cancer, but what hormone therapy can increase the risk of is a blood clot. And a blood clot, of course, is very serious. It can be life-threatening. It could be in the form of a heart attack, stroke, pulmonary embolism, which is a blood clot in the lung. But guess what? We're only seeing blood clots in oral estrogen, the estrogen that you take by mouth in a pill. And so that's why most of the menopause experts are preferentially giving transdermal estrogen. Transdermal estrogen means that we apply to the skin and it gets absorbed through the skin. It can be like in the form of a patch. No, pellets are completely different, and we'll get to that. Transdermal means goes through the skin. So we put it on the skin. It can be a patch. It can be a spray. It can be a gel. These are prescription. These are bioidentical, plant-based hormone therapy, estrogen therapy, and we are not seeing an increase in blood clots. So again, it's about how it's given, how you're monitored, but very, very few serious side effects. Unless you're using
Streicher,
pellets.
do you put those in the vaginal area, or where do you put them?
No, this is different. So because when we talk about hormone therapy, there's two basic categories. Systemic, which is what we're talking about now. This is hormone therapy that goes through your whole body, which is going to protect your bones, your hot flashes, your brain. And then we talk about local hormone therapy. Local hormone therapy is something that is applied directly to the vulva, the vagina, the genitals, and that is not going to protect your bones, your brain, or help your hot flashes. That's just for your vagina, for your vulva, for your bladder, for your urethra, for your clitoris, all the good stuff down there.
From here down, from here down.
Yeah, all down there. I was going to say, what's up down there? And that's actually specifically what slip sliding way is about. I don't get into the systemic stuff in the hormone therapy in slip sliding way. That is book 2, Hot Flash Hell, which I think will be out probably 2-3 months, depending on how fast I write. I'm pretty fast. I talk fast, I write fast. But the local vaginal estrogen therapy and all the non-hormonal things, that's completely separate because that is local therapy.
Got it. All right. Next question. Does menopause disappear? Nope. It's a lifetime thing. Are there treatments to alleviate? We spoke about that. Let's move on to what can I take for hot flashes?
I want to go back just 1 second. It's one thing I didn't say that I want to say, because we did talk about hot flashes and all that. But while we're on the subject of the vagina, one of the things that happens, of course, is that women start to experience, 70% of women experience dryness and thinning and painful sex and burning and irritation and that gotta go feeling and recurrent urinary tract infections. That does not go away. That will continue on unless you treat it. So we talked about hot flashes being average 7 to 10 years. The vaginal changes in 70% of women that have them are not going to go away. And in fact, sometimes it starts later. So women don't even know this from menopause. Hot flash, when your periods disappear, if you're getting periods and you're flashing like crazy, you're like, hey, hello, this is menopause. But if your period stopped 3 years ago, and then 3 or 4 years later, all of a sudden your vagina is like the Sahara Desert, you may not even know. And studies have shown that a lot of women don't know. They think it's aging as opposed to specifically being about, menopause. And as I think on my Instagram today, I did, my favorite quote that if, guys, if they're like penises, shriveled up and dried up and they couldn't have sex and their bones deteriorated and they could never have sex again, they would not be told this is a normal part of aging. They would be offered solutions, and which is basically, my whole mantra of, come on, this is ridiculous. We need to talk about these solutions. Hot flashes. I think we talked about that a little bit.
Yes, we
the
did.
Botanicals and all of that.
How do you know if you're premenopausal or menopausal, Dawn?
So strictly speaking, if you have not had if you're someone who gets periods, and if you have not had a period for 12 months, that means that you have now made that transition from premenopause into entering menopause. If you don't get periods, sometimes it's not clear and we don't know until later. We can do blood work, but as I mentioned, the blood work can sometimes be confusing because it is up and down. But the truth is, if I have someone who's had a hysterectomy, if they don't have a uterus, and if they're having symptoms and they don't know whether they're premenopause or menopause, I don't care. I'm going to just get rid of your symptoms. I don't have to put a stamp on your forehead that says you're premenopause or menopause. I am solution oriented. If you have vaginal dryness and pain and you're having hot flashes and you're not sleeping, it doesn't matter. It doesn't matter. We just need to get you to feel better.
It doesn't matter which one it is. Guys, I know you have a lot of questions. The folks that are on live right now, I'm going to get to those. Let me finish these. What do I do with the body change and extra pounds that are not responding to diet or exercise?
So let's talk about body change first. Even if someone doesn't gain 1 ounce in menopause, the lack of estrogen causes, a redistribution of whatever fat you have. That's muffin top.
Right here.
Exactly. Even if you are like perfectly the same weight, which is not going to happen either. But even if you don't gain an ounce, there is a redistribution, which is where Spanx comes in. Just saying. I mean, exercise and all of that. I'm a big exerciser. The extra pounds, there's so many reasons for that. Like everything else, it's multifactorial. And women do gain on the average an extra 3 to 4 pounds a year, which doesn't sound like a lot, but in 10 years, that's 30 pounds. So it adds up. And we know that some of this is because of the hot flashes. Hot flashes are associated with increased weight for a variety of reasons, both the interruption in sleep, the change in leptins, ghrelins, all of that, the inflammatory response, the cortisol, all of that makes it, you can eat the same as you did when you were 30 and you're still going to gain weight. So there's that. There's the lifestyle things. I mean, let's be honest here. Here we are. My kids are out of the house, every night. There's the wine. There's the let's go out to eat because I don't have, 4 to cook for. It's just the 2 of us. So lifestyle has a lot to do with it too. That's book 9 is when I get into weight and all that. But I don't. That's going to be probably a while off. So if you go to my website, drstreicher.com, I have an article specifically about how to get rid of muffin top and my 10 tips to lose weight in menopause. And I also want to give a shout out to my colleague, Dr. Bob Kushner, who is amazing, who has an incredible book that came out a year ago called 6 Factors to Fit, which is a behavioral approach to weight loss that works. I tell all my patients, buy 6 Factors to Fit, go to his website, go with Dr. Kushner's approach. I promise you, if you do what he says to do, it will work, because this is so frustrating. It happened to me. I am vigilant about my weight and exercise and all that. And when I went through menopause, it's like, I went and bought a new scale because I was like, I thought it's broken. This can't be
especially your clothing. You're like, what is this gut that just popped out? My pants are closing, but it's distributed differently.
Absolutely. Another thing along those lines with your belly and the gut and all that, the other thing you have to pay attention to is posture. Because what we also find over time is that women very often their posture changes, or they might even have bone loss, osteoporosis in the spine, which will cause their abdomen to protrude as well. I cannot emphasize enough, when you think in terms of exercise program, core work is so important. There's, I've been battling for the #1 spot on Amazon in menopause, and the woman I've been battling with is a woman, oh my God, and now I'm completely blanking on the name of her book, but her book was like #1 rotating with mine. So I downloaded it, and she's someone, her approach is diet and exercise, and it's so good. It goes through all of the exercises. And I'm like, oh, good. That's what I do. It's all core stuff mixed with a
Cool.
little cardio, because that is really going to go a long way. We're never going to be like when we're 20. I mean, let's face
No.
it. I can't get into those jeans I wore in high
No.
school. I mean, who would want to anyway? They were like
No, we
really
want to,
kind
yeah.
of unattractive. But but the point is yeah, there's stuff we can do, but we have to also be realistic.
Okay. What about bioidentical hormones? I don't know.
Yeah, so bioidentical hormones is probably the most common question we get. And one of the problems is that we have to define what does bioidentical mean, because bioidentical means different things to different people. So when I think in terms of bioidentical hormones, I'm thinking of a plant-derived beta estradiol, which is in every single hormone that I personally prescribe. I prescribe bioidentical hormones. But what a lot of people are talking about is compounded hormones, that they don't get these from a standard pharmacy, that they're getting them from a compounder because the compounding pharmacies are not under the same FDA umbrella. So they can market and advertise and say that what they're doing is safer and better or different than what you're getting. And the truth of the matter is that not only is it not better, but in many ways it's not as safe. So I would encourage women who are interested in doing bioidentical hormones, that they go to a menopause expert who is prescribing commercial hormone therapy. The example I always give is estradiol is the active ingredient, right? I mentioned the beta estradiol. So you want to get that beta estradiol in a form that is safe and effective, and that they are telling you the truth. So if you go and you buy cookies in the store and you buy Nabisco cookies, and the active ingredient in those cookies is sugar, right? And on the back of the Nabisco cookie box, it's going to say there's so many grams of sugar and this cookie has 200 calories. You know what you're getting. You go to the corner bakery and they say, my cookies, no sugar. You're not going to gain weight when it has the exact same ingredients.
Yeah.
But they don't have to tell you. That's the difference between compounded hormones and an FDA approved hormone therapy.
I can see right here a whole discussion about holistic treatments, someone mentioning interactive medicine, doctor in your area, and a book by an author called Suzanne Summers.
Dr. Suzanne Summers? Dr. Suzanne Summers? This is on my website. One of my claims to fame is when I was on Oprah with Dr. Suzanne Summers. All I can tell you is do not read her book. It is not medically based. There is so much in there that is just not true. It is frightening. I am a big believer in hormone therapy. I think women benefit from it. It is safe. It is an effective form of dealing with all of these changes that your body is going through. I don't take women off their hormone therapy. They are on it, as far as I'm concerned, for the rest of their life. But it needs to be done by someone who knows what they were doing. And newsflash, Suzanne Summers does not. There's also a lot of people out there who put themselves out there as longevity experts and menopause experts. And there's a couple of red flags people need to be aware of. First of all, you know what you do in order to be a longevity expert. What you need to do is take a weekend course, pay $2,000, and then you are a longevity expert. These are not real experts. Only 5% of them are gynecologists. And the big red flag is if they don't even have you take off your clothes and they just keep doing blood tests every 10 minutes and, you're paying a lot of money and they're putting in pellets and they're having you do saliva testing. Chances are you are not seeing someone who is giving you hormones in a safe and appropriate way. You need to be very careful. We see so many women, you mentioned pellets, and I just did a whole article in a scientific journal on pellets and the concerns about pellets, because pellets are very often given by people. They never do an exam. They just never examine you. They do some levels and they start giving you pellets. And what we are seeing in the pellets, and I could go on pellets for hours and I'm not going to. The short answer is there's a reason they're not FDA approved, and that's because women are getting sky high levels of hormone therapy, that they're getting complications, not only acne and hair growth in places where you don't want it, but also a significant increased risk of uterine cancer, because we talked earlier about getting an abnormal buildup in the lining of the uterus, and we are seeing this in significant numbers in women who are using compounded hormone therapy and pellet therapy. So they make it sound so good, and women go on pellets and they feel so good because it's hormone therapy. Of course you're going to feel good, but over the long term, it's not in your best interest. And I always get, a lot of flack for that, but
you can handle it.
Yeah, I can handle it.
What is the Dutch hormone test?
This is another thing you should not. I always say, take your money and flush it down the toilet. It'll be so much faster, or better yet, get some wine, get a pedicure. This is one of these at-home tests that are going to, supposedly tell you all the mysteries of menopause and what your hormone levels are. It's a complete waste of money. I'll give you an example. You do these tests and they will tell you, oh, so let's just say your last period was 5 years ago when you're 57 years old, and you do this hormone test and they'll tell you you have no estrogen. Shocking, you have no estrogen. Really? I could have told you that without the test. And then they'll tell you you have no progesterone. Well, of course you have no progesterone, because in order to have progesterone, you have to ovulate and make progesterone. So they sell this stuff like this is going to give you all this information, and it's not. I always say doing this test is like doing a pregnancy test on someone 5 minutes before they deliver and then being shocked when it comes back positive. You're not, and then there's all this information in there that's of absolutely no clinical value. So don't waste your money. Do I ever get hormone levels, blood levels? You bet. But it's in very specific situations, and I know how to interpret them. But it's not something that you're going to get at an an at-home test that you can get on the internet.
If people don't want to take hormone replacement, or they're not a good candidate, are there any holistic options?
Yeah, I would not use the word holistic. I would use the word non-hormonal that have been shown to work. So the way that we approach this, if a woman comes in and she says, I either prefer not to take hormone therapy, or I can't, if she has breast cancer or something like that. So then we get very specific. What are your symptoms? Is it vaginal dryness? Are these urinary issues? Is it hot flashes? Is it sleep? And then I'm going to make recommendations based on those specific issues. And what we find is that while sometimes it's a little more challenging, because it is true that hormone therapy works better than anything else, we find that we are generally able to help alleviate these symptoms. There's also development of a very exciting group of drugs, so stay tuned. It's called the candy drugs, which are really phenomenal in terms of, and candy with a K, not a C, sorry. Candy's great, but it's not going to help your hot flashes. Chocolate does not work, by the way. But these candy drugs actually are non-hormonal. They kind of set your temperature, your thermostat back into a normal range. They take away hot flashes, very, very few side effects. It's actually one of the reasons why I decided to do my hot flash book second instead of first, because I'm waiting for these class of drugs to be available so I can really talk about them. But there's a lot of exciting research going on.
Is there an age when it's too late to start hormone therapy?
So Sue, this is the answer. If we are talking about local vaginal estrogen therapy for the vagina, no, 90, 100, it doesn't matter. You can start at any time. If you are talking about systemic hormone therapy, we talk about either an oral or through the skin for hot flashes, what we learned from that WHA study years ago is that there appears to be what we call a critical window, meaning that the safest time to start hormone therapy is in the first 10 years of menopause. After that, it's not like we can't start it. We certainly do in some circumstances, but it doesn't have the same safety profile, and we have to be a little bit more careful about how we're administering it. So and the good news is that most women are most symptomatic with sleep and hot flashes in the first 10 years, which is the time when it's safe to start it. So it's not like it's off the table after that. It's just not the optimum time to start.
Okay. Does your period get heavy before it goes away?
The answer, Monica, is yes, it can. And the reason why is that perimenopause, women are generally not ovulating, which makes it difficult to get pregnant for people who want to get pregnant. And because you're not ovulating, you make estrogen without that all-important progesterone to balance it out. And so you get a thicker lining of the uterus. We've talked about that a little bit. And then that can cause heavy periods. Also keeping in mind that there are a lot of other things that can cause heavy periods. Sometimes fibroids, which are benign tumors in the wall of the uterus, can cause heavy bleeding, particularly in the 40s. And then sometimes we have abnormal cells, either precancerous or cancerous, which is why you never ignore it. When you look at abnormal bleeding, 90% of the time, it is not anything serious. 10% of the time, when you're looking in the 40, 50, 60-year-old age group, it is either a precancer or cancer. So we always want to check it out, but in most cases, it's not something serious. And aside from the fact that, who wants to bleed heavily, some women actually become anemic as a result of it. So you don't want to ignore it. We do want to treat it. We have a lot of treatments.
I know you want to talk about this. Where did my libido go?
Well,
I have like 5 people. Where's my sex drive?
Libido is another thing that we spend a lot of time talking about it. So when someone comes into our Center for Sexual Medicine and they say, okay, I have no libido. So the first thing I ask them is, well, when was the last time you had intercourse? When was the last time you had sex? And they'll say, it was 6 months ago. How did it go? Well, it hurt like hell. Well, of course you have no libido. Your vagina is not stupid. If it hurts like hell, you're not going to want to do it. And your brain's going to say, don't go there. Don't go in there. So the first thing we do is we have to make sure that because no one should ever have pain with intercourse or with sexual activity, ever. No pain is acceptable. None. So we have to make the pain go away if someone is having pain. If someone is not having pain, what we always say about libido is it is multifactorial. So I'm not a therapist. My daughter's a sex therapist, by the way. You should have her on. We do things together. She is quite amazing. But, but sometimes it is relationships. Sometimes it is cultural issues. There are a lot of cultural things. There might be a past history of trauma. I mean, the list is so long of things that can cause a lack of libido. I, of course, stick to the physical, hormonal, medical aspects of which, sometimes it might be a medical condition. Could be depression, could be your antidepressants. Antidepressants and other medications very often can kill your libido. Birth control pills can sometimes kill your libido. Thyroid condition can kill your libido. Obviously not getting sleep can kill your libido. So this one takes a bit more of a deep dive, but we sure have a lot of things we can do to find your libido that's been long gone.
So find it and get it back. I love your approach, Dr. Streicher, of not having to suffer through this. No. Because I was kind of disappointed when my own doctor was like, it is what it is. You're over 40. You'll never sleep again. You're going to sweat from under your boobs down to your thighs. And I was like, for real? Because I'm miserable. Plus, I have 2 little kids because a lot of us had children later in life. So
a lot of people go from pregnancy right into perimenopause. Absolutely.
So I can't surrender to this, Dr. Streicher.
No, nor should you. And, so there's another thing that I've been focusing on a lot, and that's the impact of menopause in the workplace. Because the same time when women are going through perimenopause and menopause is very often the same time that they are, at the peak of their professional careers. And suddenly they're not sleeping, they can't think. And there's a whole body of research that has been done on this in the UK, particularly, where they look at the mistakes women make, the fact that they're quitting their jobs. And, you can't go to your supervisor because your supervisor is like, 25 years old, and you don't want to tell them that, look what's happening to me. So that's actually one of my big initiatives, is addressing the impact of menopause in the workplace, because you can't just put up with this stuff. There's no reason to. There's no reason to.
No, Dr. Streicher, what is your website?
My website is drstreicher.com. Follow me on Instagram at Dr. Streich. I'm just actually getting started on Instagram, so I don't have a lot of followers. I need followers. I feel like I'm not doing my job because I don't have followers on Instagram and Twitter and Facebook, of course. And then my book is Slip Sliding Away, Turning Back the Clock on Your Vagina. And that is part 1 in my Inside Information series. And each one of those books is going to be something about menopause. And I just also want to mention, for those of you who are thinking about downloading my book, thank you. It actually went live this morning, and Amazon had a problem with formatting on the Kindle version. So if you have gotten the Kindle version and you open it up on your phone and it's not loading right, you are going to get another version in the next 24 hours. So I apologize for that. It's making me crazy, but that's what happens sometimes. But yes, it's all there, and I'm just gonna keep this stuff coming because I really want to get this information out.
I appreciate it. Thank you so much for joining me tonight. And of course,
thank you for having this conversation.
I can't believe we've come full circle from pregnancy to menopause. I'm so happy. Yes. Thank you so much, everybody. And Dr. Streicher, of course, there's her website. And we'll call you again if we have more doubts and more concerns about this topic, because there is no point in hiding this or making it taboo. Have a great night, Dr.
Can I
Streicher.
give one more quick website before we go? One more really quick
yes.
one. For those who want to make an appointment in the Center for Sexual Medicine and Menopause, it's sexmedmenopause.nm.org. Sex Menopause.nm. As in Northwestern Medicine.nm.org. You can go right on there and say, I want to be a patient. We have amazing people. We just started a vulvar clinic. We have to come back and talk about the vulva. We have a vulvar clinic. We have a bone clinic. We have a sex clinic. We have a menopause clinic. All good stuff. We've got people to help.
I love it. I'm definitely going to reach out to you. Thank you so much, Dr. Streicher. Have a good night. So there you have it. And I know Dr. Streicher and her colleagues. I've known them for many years. I've been a patient. There is nothing that you can't ask these people that they won't ask you truthfully. If you're looking for holistic approaches, then you're on your own, because this is not what they do. And you can go find those, right? But Dr. Streicher has made it a point to make this her life journey after delivering thousands of babies in Chicago, and after helping a lot of us get pregnant and navigate that new journey. And now she's helping us navigate this midlife journey till death do us part with menopause. Thank you so much for watching. Thank you for your questions and your comments. And we will see you next Wednesday on Wednesday Wine with Ana Belaval. Have a good night, everybody.